And it's give us a very great pleasure to welcome you for this oncology update. And it's a pleasure to welcome the program convener, Dr. Kumardeep Datta sir. He's a senior consultant medical oncology at the prestigious Action Cancer Hospital, Delhi. So good evening, Dr. Kumar sir. Over to you with your welcome remarks, and then we request Dr. Varun to take the proceedings, please. So Dr. Kumardeep sir, some notes from your side.
Yeah, thank you. And I welcome you all on behalf of organizing team on Media Oncology Update. In this update, we will be discussing about the recent updates and ESCO updates in breast cancer, ovarian cancer, gastric cancer, advanced RCC. And thank you for this exist. Our first speaker is none other than Dr. Piyush Goyal. Will speak on Piyush Bajpai. Sorry, Piyush Bajpai. He is a senior consultant, medical oncologist, and practicing in Delhi NCR for 8 years. So he will speak on gastroesophageal cancer updates. Over to you, Dr. Piyush.
Yeah, thanks to the organizers. Thank you, Dr. Kumardeep. Thank you, Dr. Varun, for this opportunity. So the topic I'm speaking on is on, can I share my slide? It's showing that I cannot start screen share, so if I could be allowed to. Yeah. So it's immune checkpoint inhibitors. How are they making way in the first line setting of gastric cancers, GE junction, and esophageal adenocarcinoma? So I hope my slides are visible over there.
Yes, sir.
Yeah. So as we know that this is a complex organ. The esophagus, the GE junction, and its eventually, formation into the gastric organ. So these organs definitely have a different biology. There is heterogeneity, although adenocarcinoma in the lower 1/3 of GE junction can happen, as well as stomach adenocarcinomas, but then they are different actually. Molecularly, they are different, and the causative agents are different. We see that most of the GE junction adenocarcinomas are related to refluxes, obesity, as over metabolic syndrome, one may call. The distal gastric carcinomas are different. They are caused by H. pylori. They're caused by alcohol intake. They're caused by smoking. So they are different actually, and molecularly as well. The HER2/neu enrichment ERBB2 is more so in the GE junction region. The squamous part, of course, is something like the molecular profile is quite similar to the head and neck. So that's a different category altogether. So when we talk about basically the incidences, we see that the gastric carcinomas are nearly 60,000 plus being diagnosed almost every year. And likewise, esophageal cancer is quite a similar figure over there. What is the stark, or rather, it is a sad reality that almost a similar number of patients we are losing to this particular disease every year, quite a similar number. So that's the sad part. Well, the risk factor, as I just mentioned, for the gastric is different, and the gastroesophageal junction is different, and that's what is important. The GERD is predominating in the proximal GE junction, but H. pylori is more so for the gastric, and that's important. Obesity for the cardia part is there, but then for alcohol is there for the non-cardia part. So there is a difference over there. And we all know the TNM, since we are discussing the metastatic over here. So basically, we will be talking about the M1 status in this particular talk. This is the AJCC 8 prognostic staging gastric cancer pathological classification. So what we see is this is a poor disease subset with a high mortality rate, and there is critical unmet need for new treatments that can improve upon the standard of care chemotherapy, which has been used for several years now. Current options are largely limited to doublet or triplet chemotherapy regimens. So when we talk about the guidelines, what they say is like, if it's a locally advanced unresectable or a recurrent or a metastatic disease, then we are talking about how is the performance status of the patient. And if it's less than 2, then we actually look towards biomarkers. We all are doing this. HER2/neu has been there as, the biomarkers which we ask for in metastatic setting. PD-L1 is now coming up, and MSI is also an important one, a tissue agnostic marker. So MSI, these 3 are the important ones basically. And then we actually go ahead discussing how to go about chemoradiation or systemic therapy or best supportive care. So this is important. We just discussed these biomarkers, how they are getting important. HER2/neu was there, though. It's been almost more than a decade for TOGA trial, and we are using it quite regularly. We do appreciate that there is a lot of heterogeneity involved with this particular marker. The prevalence is almost to 15 to 20% across the various regions, and prognostically, it's basically more for the G junction area, the proximal stomach, which is actually having this particular marker, the intestinal subtype. The PD-L1 is something what we are realizing now, that this is around 24 to 38% than previously reported. It might be slightly lower. Prognostic value, well, it indicates that they are associated with the inferior overall survival, and predictive value is irrespective of the PD-L1 status, although higher overall response rates were observed in PD-L1 expressors. For the MSI, of course, they are in a range of 4 to 22%, and they are associated with reduced risk of mortality, lymph node metastasis, and tumor invasion. However, association with improved prognosis remains ambiguous in light of conflicting data. And they definitely have a predictive value in terms of immuno-oncology drug response. So they are now established tumor agnostic markers. And now talking about both the tumor intrinsic factors and the extrinsic factors, which actually led to the need of this particular scores. So you have tumor PD-L1, but then this combined positive score was from the idea that the tumor milieu is important and the infiltrating cells are important. So PD-L1 staining tumor cells along with the lymphocyte macrophages, and this formula is there, which is upon the tumor total viable tumor cells. This is a percentage. So introduction to this particular drug that we are talking, nivolumab, and this is basically a PD-L1 blockade inhibitor, and we can see that it actually releases the brake of the pro-inflammatory cells, the T cells, the Tregs, which actually start, hitting the tumor, and eventually cell death, the tumor cell death takes place. So we're talking about Checkmate 649 today, and this was the trial, one of the global trials basically, and a phase 3 study for first-line treatment of advanced upper GI cancers. And here the enrollment was unresectable metastatic GE junction gastric esophageal adenocarcinoma. They all were HER2/neu negative and PS01. So the stratification was PD-L1 expression greater than 1% or less than 1%, and ECOG was good ECOG. They were distributed as stratification factor was also, since the chemotherapy arms were, the chemotherapy was left to the physician, so Capox or Folfox. So if it was Capox, then the nivolumab dose was 360 mg once in 3 weeks. If it was 2 weekly Folfox, then it was dosed at 240 mg. nearly a 1:1 randomization. The standard arm of chemotherapy, Capox and Folfox was there in its usual interval protocols. The dual primary endpoints was overall survival and PFS, and it was in PDL1 CPS of more than 5, which was there. And secondary endpoints were there, which included checking of the survival, overall survival in CPS1 greater than 1, overall survival in CPS greater than 10, PFS in PDL1, CPS more than 10, 1, or all randomized. Then overall response rate was looked at, and then there were exploratory endpoints, and that was safety and quality of life parameters. So the statistical testing was basically the PFS and the overall survival. It was like if you are actually obtaining positive results for a CPS of greater than 5, then actually you go ahead and check for overall survival. Statistically, formal statistical analysis was done if for overall survival PDL1 CPS greater than 5, and then overall survival for all randomized patient was done. Well, likewise, overall survival for PDL1 for CPS more than 5 was achieved. Then overall survival for PDL1 CPS more than 1 was done, and then again for all randomized. So basically, all primary and hierarchically tested secondary endpoints for Omdita and Folfox or Capox were met at the 12-month follow-up. You look at the baseline characteristics, which were well balanced between both the treatment groups. So the gastroesophageal junction, as we can see, the gastric cancer was predominating over there, almost 70% in both the arms. And PDL1 expression, well, it was more than 1% in a quarter, basically. So what we see is a lot of liver disease, liver metastatic disease, and signet-ring cell carcinoma is also there, 15% of the patients. And then you have MSI high, again, included over there, 4%, nearly 4% and 3% in both the arms respectively. Folfox or Capox, as we can see, almost equivalent distribution of these two chemotherapy regimens in both the arms were there. So our nivolumab and Folfox or Capox demonstrated overall survival benefit irrespective of PDL1 status. And this was there in the all randomized. There was a 2-year overall survival rate of 28% versus 19%. When we look at the CPS greater than 5, greater than or equal to 5, then it was 2-year overall survival was 31% versus 19%. Well, when we talk about the PFS benefit, it was maintained with the nivolumab and Folfox or Capox with longer follow-up irrespective of PDL1 status. Talking about the overall response rate, the other secondary endpoint which remained higher and duration of response was longer with nivolumab and Folfox or Capox versus the chemotherapy arm. Talking about overall response rates in MSI high, where you do expect that this would actually have good response rates and result in better survival. Here again, longer median overall survival and higher overall response rates was observed in all randomized patient with this particular subset of when nivolumab was combined with chemotherapy over there. Consistent overall survival improvement was seen across all the pre-specified group, whether the primary tumor location was gastric carcinoma, GE junction, or esophageal adenocarcinoma. So it's pretty consistent in the addition of this particular drug. Also, if you see the PDL1 expression is, both the less than 1% and greater than 1% getting the benefit of this drug. The MSI status, of course, as we can see, is getting the benefit. Liver metastasis is getting the benefit. Also, signet-ring carcinoma is the hazard ratio is less than 1. So basically, all pre-specified in subgroups were actually benefiting with the addition of this drug. And for PD-L1 CPS less than 1 and less than 5, if we see that the hazard ratio was actually quite in favor in both the groups, it was less than 1 as compared to, numerically it was the figures were higher in the combination arm versus chemotherapy arm. And the combination did demonstrate a higher overall response rate and longer duration of response across CPS cutoff. And overall response rates was high with the combination or Kipox versus Folfox or Kipox, and duration of response was longer. So basically, this is what 42% of all patients randomized to the combination versus chemotherapy received subsequent treatment. And we can see that a lot of patients received taxanes over there. Ramucirumab was also there in certain patients. So the most subsequent subgroup, the most subsequent therapy was actually systemic anti-cancer therapy. And no new safety signals were observed when this combination was studied. So there weren't any new safety signals, although numerically there were more numerically more side effects as compared to the chemotherapy arm. So immunological side effects, if we see grade 3 or 4 with the addition of this drug to chemotherapy, well, not going in above 5%. So most of them 1 or 2% grade 3-4 side effects, the immunological ones. So regarding the quality of life issues, it did not result in additional bother from treatment side effects as per this score sheet, FACT-GA, GP5. So the quality of life was maintained, and you can see that it did not result in deterioration of quality of life from baseline for patients with CPS more than 5 as per GCS, EQ5D, and EQ-VAS assessment scores. So addition of immunotherapy to Folfox or Kipox did not result in deterioration of quality of life from baseline. And the least squares mean difference between the treatment groups favor the nivolumab plus Folfox or Kipox versus the chemotherapy alone. So there was a decrease in risk of symptom deterioration when in the combination, irrespective of PD-L1 CPS status. And again, lower risk of deterioration with the combination, as we can see in this. So overall, basically, the risk of quality of life issues were deteriorating less with the combination as compared to the chemotherapy arm. So currently, the approval in our country is basically for the combination is for basically advanced or metastatic gastric cancers, GE junction and esophageal adenocarcinoma. And you can choose basically the dosing 240 mg or 360 mg based on the chemotherapy partner that you're choosing. And the maximum treatment duration is 24 months basically for this. And to summarize that nivolumab is the first PD-1 inhibitor to demonstrate superior overall survival and PFS in combination with chemotherapy versus chemotherapy alone in previously untreated advanced gastric carcinoma, GE junction, and esophageal adenocarcinoma patients. Superior overall survival benefit was found more than 28% amongst all the randomized patients, and high response rate, 58% patients receiving the combination responded, included 11% complete responders irrespective of the PD-L1 CPS status, and therefore that makes it a point to actually consider whatever the PD-L1 score is to consider the combination. So no new safety signals were observed, and the addition of this drug to chemotherapy maintained the quality of life basically, and decreased risk of symptom deterioration, and no additional bother from side effects. Longer follow-up and further support, longer follow-up of the combination to further support its use as a new standard first-line treatment in patients with advanced gastric carcinoma, GE junction, and esophageal adenocarcinoma. So thank you.
So thank you, sir. Congratulations. This was a very lucid presentation, and you have covered all the salient points. So just, sir, I want to ask one question with your permission.
Yeah,
So
yeah.
so as you have already shown that combination with Folfox or Capox, this nivolumab is already recommended for G junction and gastric cancer. But if we see NCCN guideline, they specifically quote that if CPS is more than equal to 5, then we should add these drugs. And if less than 5, then according to NCCN, it is category 2B recommendation. So what your take on that? Like if we see in detail these trial results, there is no difference according to hazard ratio or according to other results. There is no difference on the basis of CPS value as far as I got like this trial. So what's your take? Whether we can use nivolumab in combination with Folfox in first line G junction, even if CPS have been done or not, whether there is need for two CPS to be done, or if less than 5, then what we should do?
So basically, since it's approved in our country for, this particular above anything above, irrespective of PDL1 or above 1%. So we can actually consider not doing it, because there are patients who are still benefiting in PDL1 less than CPS less than 5%. So what we see is numerically these survival figures are definitely more. Number two is that the quality of life issues were better, symptom deterioration was lesser. So yes, for above CPS 5, the MCBS ESMO scoring is 4 and above, 4 rather. But of course, for less than that, it makes a point to consider these particular factors if in case we want to use.
Yes, yes.
And
so
also the tail of curve is important. So sometimes we do not get the perfect idea with the median figures. So the tail of the curve in immunotherapy is important. And that some percentage of these patients still continue to get benefit with its use.
Yes, sir. So I think so, like same as you have already mentioned, that already we have added this drug to Folfox in first line G junction for maybe 3-4 patients, and we have seen good results. And we have already doing in maintenance also. So that also important, because after completion of chemotherapy, maybe most of the patient tolerate it by 8 to 12 cycles, by around 10, then tolerance issue is there. After that, if we can continue these drugs, IO agents, then PFS increases and patient quality of life improves. So with this, we will go on to next session. So I will welcome Dr. Kshitiz. Thank you, sir. So I will welcome Dr. Kshitiz. He is my colleague and senior consultant in Ahmedabad. So he will take session on rapid changing landscape in advanced RCC treatment and need for personalization. So this session is sponsored by Merck. And so over to you, Kshitiz.
Yeah, good evening, sir. Good evening.
Good evening.
Thank you for giving me this opportunity, sir. So I just take the liberty to share my screen. Yes, the slides are visible, sir.
Yes, sir.
Okay.
Visible. You are
so okay. So the topic given to me is management of the first line options in renal cell carcinoma, with special focus on evolumab plus exitinib. So as far as systemic treatment of advanced renal cell carcinoma is concerned, till few years back, we only had options of VEGF tyrosine kinase inhibitors. But since last couple of years, with the advent of the role of checkpoint inhibitors in advanced renal cell carcinoma settings, we have seen a paradigm shift in the management of metastatic renal cell carcinoma, with various options like IO plus IO combinations, as well as IO plus TKI combinations, in the first line management of advanced RCC. So if we see prior trials of tyrosine kinase inhibitor, what we got was a response rate of about 20 to 30%. And if we see the overall survival figures, we got a median overall survival of about 20 to 30 months with tyrosine kinase inhibitors. So in the first quarter of 2019, we got the results of Javelin renal trial, which was published in NEJM, and that showed positive results of a PD-L1 inhibitor, that is nivolumab, along with VEGF receptor tyrosine kinase inhibitor, that is axitinib. Okay, so if we see the trial design, very well conducted study. It was a phase 3 trial. If you see the eligibility criteria, it included patients who were treatment naive, advanced RCC with a clear cell component, having more than or equal to 1 measurable lesion. The tumor tissue should be available for PD-L1 staining. So PD-L1 was done using SP263 clone by Ventana platform in this particular trial. And patients should be having a good performance of either 0 or 1. And the patients, they were stratified based on the performance status and the geographic region. They were randomized 1:1 to either avelumab in the dose of 10 milligram per kilogram every 2 weekly, along with axitinib, the dosing of 5 milligram oral to be taken twice a day, versus sunitinib. The schedule of sunitinib was 4 weeks on, 2 weeks off in this particular trial, 50 milligram oral. And if you see the outcome measures, the primary outcome, the primary endpoint was progression-free survival and overall survival in patients with PD-L1 positive tumors. In the key secondary endpoint, where the progression-free survival and overall survival in the entire population. And there were certain additional secondary endpoints like objective response rates, time to response, duration of response, and safety as well. Now, before moving towards the results of this particular trial, let us see the rationale of combining a checkpoint inhibitor along with a VEGF receptor. So as we all know, renal cell carcinoma is a vascular tumor in which VEGF plays a very key role. VEGF, it leads to immunosuppression. Whenever we are giving a TKI which is against VEGF receptor, so it may enhance the T cell mediated cytotoxicity, and that can be further increased by giving checkpoint inhibitors. So there can be a synergistic action if we combine a checkpoint inhibitor along with a VEGF receptor TKI. So that is the basic rationale behind combining an IO agent along with a TKI. So if you see the overall population breakdown according to the prognostic risk criteria, the two most commonly being used are IMDC and the MSKCC. About 20% were of the favorable risk group, and about 60% were poor. And if you see that, if you combine the intermediate and the poor one, about 70-75% were intermediate poor, and about 20% were of the were in the favorable risk groups. Now, if we see the median progression-free survival in the entire population, in the overall population, so that favored the arm of avelumab plus axitinib. 13.3 months was the median PFS versus 8 months, and it led to a 31% reduction in the risk of disease progression, an absolute improvement of 5.3 months. So these were the results in the entire population. If we see the primary outcome measure, that is the progression-free survival in the PD-L1 positive population. So it was 13.8 months versus 7 months in the favor of avelumab plus axitinib arm, with a 38% reduction in the risk of disease progression, an absolute improvement of 6.8 months. If you see the forest chart, nearly in all the subgroups, they had a benefit with this particular combination arm. Very important, if we see the response rates in the comparator arm, in the sunitinib arm, the response rates are about 27.3%, and in the avelumab plus axitinib arm, the response rates were 52.5%. So we can tell near doubling of response rates, which can be seen, which can be noted with this particular IO plus TKI combination. If you see the waterfall chart, it shows very nice waterfall chart in favor of the combination. 52.5% was the confirmed overall response rate. The median time to response was 2.7 months versus 4 months in the sunitinib arm. So that is, the response rates are really in favoring the IO plus TKI combination, along with the duration of response. So if you see an endpoint, that is PFS2, which is considered to be as a time from the date of randomization to discontinuation of the second line treatment or death from any cause, whichever occurs first. So it is in favor of the avelumab plus axitinib combination. If you see the charts, they are quite separate from each other. In the experimental arm, it is not yet disclosed, versus 19.4 months, with a 45% reduction in the risk of disease progression or death. Overall survival, only the interim analysis has been done. And till now, it is in favor of avelumab plus axitinib combination with hazard ratio of 0.79. And if you can see the curves, they are separating quite early, and they are still wide from each other. If we analyze the patients who received the subsequent therapy in this particular clinical trial, nearly 31% of the patients in the Bavencio group, in combination with axitinib arm, they received the subsequent anti-cancer drug therapy, compared with 51% in the sunitinib arm. If you see the adverse events, nearly everybody had any adverse events. The most common being diarrhea, hypertension, and fatigue. But again, grade 3, grade 4 adverse events were very less in Bavencio with axitinib arm. So the same toxic effects which were expected out of any checkpoint inhibitor. Now, if we, what do we have options as far as checkpoint inhibitor are concerned in renal cell carcinoma? Either we have option of a combination of an IO plus IO, that is nivolumab plus ipilimumab, or we have options of using IO plus TKI. In this particular group, we have various options like what I have just mentioned, that is avelumab plus axitinib. We have option of pembrolizumab plus axitinib. We have option of nivolumab plus cabozantinib, and we have option of lenvatinib plus pembrolizumab. So these are the various options we have as of now for the management of RCC. So if we see, if we compare IO plus IO strategy versus IO plus TKI strategy, we can see that early responses are expected with the IO plus TKI strategy rather than IO plus IO strategy. As shown in this chart, the Checkmate 214 PFS chart, it shows that the separation of curves are quite late with IO plus IO strategy. So this strategy is not useful when we want a quicker response. So not suitable for bulky tumor or case where rapid response is contemplated. In contrast to what we see in a strategy using IO plus TKI, where we can expect an early separation of curves, as shown in the Javelin trial, where we can expect the curves to be separated as early as about 2 months. So now some points regarding axitinib. So what is a special characteristics, or what are the USPs of this particular molecule? One thing is that it's a very selective inhibitor of VEGF receptor, unlike the other TKIs. So having very few offshoot target effects, it is having a very short half-life. It is having even the shortest half-life amongst the all other TKI, just 2.5 to 6 hours. And that is the reason why it is having a quite manageable safety profile. So if we see what short half-life does is, it leads to, it supports the combination therapy. Even there are various overlapping toxicities amongst checkpoint inhibitors and tyrosine kinase inhibitors. And in such a scenario, also a short half-life TKI is better. Even the time to resolution of grade 3 adverse events will be faster because of the shorter half-life with exitinib. And as I told, it's having very few off-target effects. It's a very specific TKI targeting the VEGF receptor 1, 2, and 3, and very few off-target effects. So this is, if we compare all the trials of IO and IO TKI, we can see that if we see the response rates, it is not appropriate to go for a cross-trial comparison, but if we see the response rates across trials, what we can see is the response rates with a combination of lenvatinib plus pembrolizumab is the tune of about 70%. Numerically, it is considered to be as the most strong compared to the other approaches. If you see the median progression-free survival, it's about 24 months with the lenvatinib plus pembrolizumab combination. And the largest follow-up till now is with nivolumab plus ipilimumab. So these were the salient points which I wanted to highlight. Okay, if we see the side effect profile, if we compare the side effect profile of various such approaches, avelumab plus exitinib seems to be most tolerable. If we see the discontinuation rates, they are very, very less compared to the other approaches. If we see the dose reduction rates, they're also very, very less as compared to the other approaches. So as you can see, if you see the usage of corticosteroids in nivo plus ipilimumab, the use of high dose corticosteroid for immune-related adverse events management were 35% versus 11% with the avelumab exitinib versus 27% with the pembrolizumab combination. So the usage of high dose corticosteroid is very, very less with the combination of avelumab plus exitinib. And even you can see the very lesser rates of discontinuation because of treatment adverse events compared to the other approaches. Okay. So what after first line? So as we all know, these are the important trials in post first line management of the advanced RCCs, where we have a good amount of data with everolimus, exitinib was compared with sorafenib, cabozantinib was compared against everolimus, nivolumab versus everolimus, lenvatinib plus everolimus versus everolimus. So these are all the important data sets which we have post TKI, post first line therapy. And we see, if you see the data part, the data of cabozantinib is fair enough. The data of lenvatinib plus everolimus in the second line is also good. Data of nivolumab is also there. So this can be used, this can be reserved for later lines as well. So there is basically no any clear advantage. There are no any head-to-head trials as of now to compare which approach is better. There can be various factors which one can consider in choosing the combination for our patient. It depends on what's the treatment goal, what is the toxicity profile of the combination, what is the frequency of infusions, the half-life of TKI, efficacy versus safety needs to be balanced. What are the options which are available for the second line post progression? So these all factors need to be considered. So as far as this particular trial and this particular combination of nivolumab plus exitinib is concerned, it leads to a longer median PFS with 31% risk reduction in the overall population. 13.3 months was the median overall survival. Median PFS in the overall population versus 8 months. Nearly twice the response rates were expected, about 25% versus 50%. There were very fewer discontinuation rates with this combination. It had a consistent PFS benefit across the subgroups. The median time to response was faster with this combination, and this combination was considered to be as safe. Very few high dose corticosteroid usage was considered if we compare the other trials as well. The dosing part, it's given as 800 milligram IV infusion over 1 hour, be given every 2 weeks. Hexagram dosing, the starting dose is 5 milligram twice daily, and then it can be titrated upwards to 10 milligram twice a day, having a close look at the blood pressure of the patient as well. So I think that's it. I again thank the organizers for giving me this opportunity. Thank you.
So thank you, Chitish. That was wonderful presentation, and like you have covered very confusing area. Like there are multiple options and multiple choices of basket, out of which we have to choose one. So you tried to explain how we should choose that, but still, so it will remain myriads of choices there for first and second line of RCC. So as far as I just want to ask, like out of all IO agents, your experience and if there any difference in toxicity profile and your preference in first and second line.
So again, first line metastatic RCC, the patient is in favorable risk group. In my practice as of now, I still use either sunitinib or pazopanib in the favorable risk group. But in the intermediate or poor risk group, I do counsel them for checkpoint inhibitors. Seeing the data, I see.
Just to interrupt once. So,
yes,
like
yes.
as you have told that obviously we see hence risk stratification and these good risk and poor risk, but if we see NCCN guideline, they don't consider that risk stratification anymore, and they give everything to every patient. What you say?
Yeah, definitely. That is going to be the future as well. But as far as the practicality of giving checkpoint inhibitor is concerned, I think it is still better to look at the risk profiles and then to choose our decision.
Yeah. So obviously, very temptly say that we should use this risk stratification more oftenly. And every patient of RCC, first we should stratify our patient whether we should go ahead with TK alone or TK with IO or IO. So as per my experience, we have used avelumab with axitinib for few of our patients in RCC in first line, and avelumab as per maintenance drug for urinary bladder for after first line if patient is in CROPR. So if I want to compare, like not much experience, but still out of all IO agents, avelumab is a good drug, no much toxicity issues, and like good responses. So as I've told that more experience should be there to quantify that statement, but still. So with this, we will thank you, Chitish. We will go on to next session. So next session, as per schedule, should be given by Dr. Smith, but he's on the way as usual. So he will take time. So till then, I will present next session and on NSCLC. So my topic is how we should decide, like for the treatment of EGFR mutation NSCLC patients, what factors we should consider for a patient, and like obviously this is age old debate whether we should go ahead for sequencing from second generation to third generation in EGFR mutation NSCLC advanced and metastatic patients, or we should start with third generation only. So are there any factors to decide this? So first of all, as we all know that lung cancer is the most common cancer incidence and mortality wise, if we see all sexes and in males also. So there are around 2.94 million new cases per year and around 1.8 million mortality per year according to Global data 2018. So in both sexes combined, lung cancer is the most commonly diagnosed cancer. It accounts for around 11.6% of total cases, and it is the leading cause of cancer death. Around 18% of the total cancer deaths are due to lung cancer per year. So to further diving into deep, just to consider like what parameters we should see in a trial, in a study, which determine the choice of first-line treatment in advanced EGFR mutation and SCLC. So whether out of these statistical analysis, PFS, OS, overall response rates, so out of which is more important to us. So it may depends on like tumor burden and patient symptoms, and whether brain mets were there or not at presentation, or those brain mets are patients are symptomatic for those or not. So if patient is symptomatic and we need good response, early response upfront, so this is also a factor. And most of all, safety and toxicity profile, quality of life, and patients who are receiving subsequent therapy upon progression. So this last point is very important to counter the argument for sequencing. So we are going to discuss about these different parameters in future in this presentation. So if we see, there are three generations. We all know three generations of EGFR TKI. First generation are gefitinib, erlotinib. Second generation are afatinib and dacomatinib. Third generation is osimertinib. So although cross trial comparisons are not allowed, should not be allowed, and but still for references, obviously head-to-head study are not available at present. So for reference, if we see median PFS in first generation TKIs are around 10 to 12 months. In second generation TKI, 11 to 15 months. So slightly better than first generation TKI, but not much. But in third generation TKI, landmark trial Flora, they have shown that PFS is around 19 months. So if we compare from gefitinib, it is around double, almost double from the first generation TKI. So osimertinib have provided unprecedented improvement in the PFS in Flora study. So if we see regarding this PFS in Lux Lung 7 study, they have taken brain mets patient, but those patients are asymptomatic, and around 16% patients were with brain mets at presentation. In Archer study, it is very surprising, but still they have excluded all brain mets patients. So in Flora study, brain mets patients have been taken even more than Lux Lung study, that there are around 20% patients with brain mets at present. Should be stable. If symptomatic, then after radiation, otherwise asymptomatic patients. So beside this point, what this Kaplan-Meier plots, I want to emphasize that with Lux Lung 7 study, in Lux Lung 7 study with afatinib, so afatinib versus gefitinib, they have compared, and both the graphs are crossing each other, like separate from each other after a gap of around 1 year. So till 1 year, there is no difference if we use first generation or second generation TKI. In Archer study, this gap is after 6 months. The separation is after 6 months. But in Flora study, if we use third generation TKI in those patients, so this benefit of the third generation TKI, if compared to the first generation TKI, is from the beginning only. So there is immediate separation of the curves with the initiation of the treatment. So early separation of PFS curves is shown by osimertinib only. Otherwise, with afatinib, 12 months later separation occurs. In dacomatinib, 6 months later separation occurs. So this is regarding PFS. So just we should not go for just for numbers. We should see what is the exact mechanism and how these curves are separating each other and when. Then next is overall response rate. In Lux Lung 7 study, overall response rate with afatinib were 70%. With first generation TKI gefitinib, it was 56%. So median duration of response is better. Obviously, it is 10.1 months, and so duration of response is 12.7 months. So it is better, obviously, in the second generation TKI is first if compared with the first generation TKI gefitinib. Similarly, in dacomatinib study, overall response rate is 75% versus 72% only with gefitinib. So not much difference. Median duration of response is 14.8 months versus 8.3 months. So statistically, this also significant. In Flora study, overall response rate is 80%. So if we just want to compare from afatinib or dacomatinib, it is 70 versus 75 versus 80%. So best overall response rate with the third generation TKI. And even 7% patients have shown complete response, and then most of the patients have shown partial response. Duration of response is around 17.2 months. At landmark of 12 months, 1 year, 64% patients are still showing response. And at the landmark of 1.5 year, 50% patients still showing response. So osimertinib has shown highest overall response rate and median duration of response if we compare these 3 studies. Next point is overall survival. So if we see final analysis and with the long follow-up, overall survival with the osimertinib arm is 38.6 months versus comparative EGFR TKI, that is first generation TKI, it is 31.8 months. So hazard ratio is 0.79 and p-value is statistically significant. So we can clearly see here that both the graphs of these Kaplan-Meier plots are separating from the beginning only and remain separated till the last. And even after 3 years of follow-up, 50% patients on the osimertinib arm are still ongoing and showing responses and taking treatment. So median overall survival is more than 3 years. So this was unprecedented before this study and haven't seen earlier in these NSCLC and advanced NSCLC patients. Osimertinib patients were more likely to be alive at 2 and 3 year landmarks, and first time an EGFR TKI has translated PFS to a significant OS benefit. So this is very important point. In other studies, either Lux Lung 7 study or documented study, they haven't quoted any OS benefit with those drugs. There was no OS benefit with those drugs, although there is some confusion of hierarchical statistical system or in documented study, but still numerically they have shown that there is PFS improvement, but there is no OS improvement with the second generation TKI. But in third generation TKI, FLORA study, OS benefit was there, and that was statistically significant. So afatinib failed to improve OS versus gefitinib in Lux Lung 7 study. In Archer study, although numerically there may be OS benefit, but because of this hierarchical gatekeeping procedure, which was used for hypothesis testing. So what was that? They have quoted earlier that during the protocol submission that if PFS improvement will be statistically significant, then they will go to see overall response rate. And if that is statistically significant, then only they will go for OS analysis. Because overall response rate was not statistically significant, hence formal statistical hypothesis testing for overall survival was not concluded in this study. So phase 3 Archer 1050 trial regarding this documented use, they have already excluded patients with brain mets. So as I've told you that in NSCLC patients, in advanced NSCLC patients, it is 20 to 25% chances that patient have brain mets. So those patients in this study have been excluded, although it reported a numerical improvement in overall survival of 34.1 months of dacofatinib arm compared to 26.8 in gefitinib arm. But because of the hierarchical statistical design, they haven't done analysis of OS. So 28% of the patients were still receiving osimertinib at 3 years, and these 28% patients were still alive and taking drug regularly without much side effect with good quality of life. And if we compare with the another comparator TKI, first generation TKI, then this number is only 9%. So osimertinib demonstrated a superior systemic PFS benefit regardless of the CNS disease status. So they have done that subgroup analysis, and what they have done, analyzed that if in around 20% patients were with upfront brain mets. So if patient with brain mets or without brain mets, whether in difference of PFS with the use of osimertinib, so they have shown that hazard ratio in both the subgroup is 0.47 or 0.46, same, p-value is statistically significant. So whether brain mets are there or not upfront, so osimertinib have shown good responses and PFS improvement. So CNS progression event occurred in 17% versus in 6% versus 15% patient receiving osimertinib versus standard care. So there is term CNS PFS, and with osimertinib they have analyzed and reported that median CNS PFS have not been reported with not reached with osimertinib, versus in first generation TKI it is 13.9 months. So this also is statistically significant difference. CNS PFS was statistically significant better with osimertinib if you compare with the comparator first generation TKI. So whether the significant CNS response have been seen first time with the first line osimertinib or in other TKI also. So in this busy slide, what I want to emphasize that intracranial or CNS response have not been assessed in LuxLung 7 and 3 or 6 studies. And in documentary study, Archer study, they haven't taken those patients. Patients with brain mets were excluded from Archer study. So out of all these 3 studies, Flora was the one in which they have analyzed this CNS TFS and have shown that this is statistically significant. What about safety profile? So this is very important point, especially regarding documentary. So grade 3-4 adverse event with documentary were reported in 63%. So this is a huge number. Like around 2/3 patients will show grade 3-4 side effect. It's not about any grade, it is grade 3-4 side effect. So in those patients, either drug dose reduction or delay or discontinuation have been seen. So if any grade or like more than 3 grade side effect with afatinib arm in LuxLung 7 study was 31%, and osimertinib arm it was the least. Only 18% patient in Flora study have shown grade 3-4 side effect. If we see side effect profile, so almost similar side effect profile, same EGFR related side effect, acneiform rashes, stomatitis, diarrhea, fatigue, but least numbers in Flora study. So with afatinib, skin side effect were 9%, with afatinib it was 14%, with osimertinib it is less than 1% only. And on the other hand, diarrhea 13 versus 8 versus 2% only. So as I've told, because of these significant grade 3-4 side effect in both Archer study and LuxLung 7 study, significant dose reductions of these TKIs have been done. In LuxLung 7 study, adverse event leading to dose reduction were more frequent in patient receiving afatinib, that is 41% versus 1% only. In Archer study, more dose reduction have been seen in documentinib group, that is 66% versus 8%. On the other hand, in the Flora study, frequency of dose reduction were similar in both the arms, osimertinib versus standard of first generation TKI, 4 versus 5%. So we can clearly see here that in osimertinib arm, in Flora study, most of the patients have tolerated drug very well. There are very less grade 3-4 side effect, and there is no need to decrease the dose. What about quality of life? So quality of life, obviously, if there are more side effects, then quality of life also hampered. So in Flora study, global quality of life was improved from baseline in both osimertinib and EGFR TKI group, and there is no much difference with the third generation TKI. So now coming to this slide, this is very important slide, and this is mainly against the motion that we should use sequencing. Like so what I want to say that if we use sequencing, like if we use first generation followed by second generation or third generation, or start with second generation followed by third generation, then what is the problem? So problem is that 1/3 of all EGFR mutation patients, if we treat with first generation or second generation TKI, only 1/3 patient will receive second line osimertinib only if patient is eligible for that. So to explain that numerically, let's say example, we have 10 patients and we have started with either first or second generation TKI. So what happens on progression? Only 70%, 70 to 75% patients will be eligible for second line treatment. Otherwise, rest patients either die due to the disease progression and will not be benefited with the second line osimertinib, or just receive palliative care. And in most of those patients, even T790M mutation testing will not be held. So these 7 patients out of 10 patients, they are eligible for T790M test results, but only 60% patients out of initial 10 patients will go on to for this testing, 790M mutation testing, and that is maybe due to lack of tissue biopsy. Patient may not be willing, patient may not be having significant tissue for biopsy, and there may be some problem with the standardization of the sample. There may be some false negative testing. So from the 10 patient, now remaining 6 patient only, and those patients, if we do T790 mutation, 50% patient will show mutation positivity, rest will show negativity. So as I've told you that only 1/3 patient, so 3 out of 10 patients will be treated with second line osimertinib. Only 3 patients will be eligible for second line osimertinib. So rest 7 patients will not be benefited with the third generation TKI if we have used that earlier in the first line only. So 7 out of 10 patients who start on first generation, second generation TKI will not be able to receive osimertinib in the second line, and it is not possible to predict which patient will develop T790M mutation resistance. There are no soft or any other parameters based on which we can say that this patient will be T790M mutation positive more likely, or will get benefit from the second line osimertinib more likely. There are no such parameters. So on the basis of which approximately 1/3 of the patient will not have access to second line treatment, and this is the main problem with the sequencing. Although there is some real world evidence from the about the T790 mutation testing, if we have used afatinib earlier. So in a Japanese study, only 43% patients of treated with first line afatinib which have T790 mutation. In Taiwanese study, 48% patients who were re-biopsied have acquired T790 mutation. In another Taiwanese studies, 28 afatinib treated patient T790 mutation have been identified in 32% patients. So real world scenario, even this is even less than this 50% value. So as I told you that in whatsoever patient we are going to do this.
Hello. Hello.
So Pooja,
Yes, sir.
like due to some technical error, my computer have been switched off. So if you can share slides from your side,
Sure, sir.
from where I left.
Sir, we don't have your slides, sir.
I'm just sending.
Okay.
I've sent.
Sir, just give me 2 minutes, huh?
Yeah. Yes. So sorry for inconvenience. So just next slide, please. I have already discussed about this slide. Next slide, please. This also I've already discussed. So regarding the sequencing of EGFR TKI, so if we start with prior generation EGFR TKI, either first generation or second generation, then if we want to treat those patients on the development of EGFR T790 mutation with third generation TKI, so this is not optimal clinical care because there are few minor points which we should consider, which should decide. So we are not smart enough to figure out which patient will get EGFR T790 mutation. So out of those 10 patients, earlier, like around 2 patients who have not survived after first generation TKI, or those 3 patients in which we are unable to do biopsy. Out of those 5 patients, maybe there are few patients who are already T790 mutation positive, but because of that, first or second generation TKI have not been useful, but still we haven't given appropriate drug to those patients. That was a problem. So not everyone will be well enough to receive additional treatment. Only 30% patients will receive subsequent therapy. So there is problem of tissue or liquid biopsies and standardization because we sit in RGCI. So it is very simple and easy for us just to go ahead with liquid biopsy if no tissue biopsy is available, but it's not the case for every institute. Osimertinib associated with significant survival benefit even in the first line. So as the dictum say that we should send best better upfront for the opening. So why not here? We should use first best drug in the first line only. Why we should hide this drug for the later line? So there is no explanation for that. So next slide, please. So uncontrollable factors in sequencing are toxicity of drugs. So there is more toxicity in the first and second generation TKI if we compare with the third generation TKI. So occurrence of T790 mutation, we don't know in which patient this T790 mutation will be developing on the course of treatment and or not. Which site disease will progress, whether we will be available able to do biopsy from that site or not, whether liquid biopsy available in our institution or not. So some concurrent mobility and patient choice are also some uncontrollable factors in sequencing if we choose for that. Next slide, please. Even NCCN guidelines, if we see, so although NCCN pleases everyone, so they have given all the TKIs, rather first generation, second generation, third generation TKI as a first line option, and all are category 1 option. But still, if we see here, so they have given osimertinib preferred choice out of all TKIs. Next slide, please. So to summarize, osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in the overall survival. This is the most important point regarding this FLORA study. This is the first drug in which OS survival have been quoted. The median OS benefit of greater than 3 years, which has not been seen earlier with any other drug in these advanced NSCLC patients. So it has sets a new benchmark for osimertinib and provide a window for opportunity for the management of these patients with stage 4 with sensitizing mutation, and reaffirm that it's important as a first line therapy. FLORA is the first time an EGFR TKI has translated PFS into OS benefit. Nearly 30% of the patients remained on osimertinib even after 3 years. Osimertinib is the only drug which can be given in patients with brain mets and with T790 mutation. So as we have shown, discussed earlier, in tecometinib study, there was no brain mets patient. In afatinib study, they have taken brain mets patient, but they haven't analyzed any brain PFS. So we don't know whether those patients have been benefited with afatinib or not. Osimertinib is the safest and least toxic drug among all the available options, and sequencing can be considered best strategy. Can't be considered best strategy because 70% patient who may be eligible for osimertinib but will not get osimertinib in the second line because of the sequencing. So these data confirm that osimertinib should be the first line standard of care in metastatic EGFR mutation NSCLC patients. Next slide, please. So with this, thank you. I will conclude my slide. Any query from my attendees or my seniors? So you may ask. If no question further, then we will go ahead for the next session, and that session will be taken by senior Dr. Sumit sir. And
hello, Dr. Varun.
over
Good
to
evening.
sir.
Yeah, good
sir.
evening, Dr. Varun. Am I audible?
Yes, sir.
I just open my computer, just engage for another 2 minutes. I'll be up and about.
Yes, sir. Yes, sir. Yeah.
Okay. So
So, sir is going to take session on flexible future transforming the paradigm of HER2 positive breast cancer treatment. So this is regarding their new combination of trastuzumab, pertuzumab, Pasco. So, so obviously this is very interesting. This drug we can give just as a subcutaneous injection, and no need for any hospitalization or admission even in daycare. So patient will be happy, and efficacy also wise, they have quoted Roche people that this is same. So regarding that, we are going, we will discuss, and sir will take us to that. So sir, over to you.
Yeah. Good evening, everyone. Hello, am I audible?
Yes, sir, you're audible. Slides are visible.
Okay, thank you very much. So let's proceed. Thank you, Varun, very much. Thank you, organizers and the sponsors, for giving me this opportunity today. I just barely reached. Thanks for coping up with that and not taking much of time. This is a sponsored session by Roche. As we know, the science is continuously evolving and we need to evolve too. And we need to learn many new things which come our way. So one such thing is the administration of the pertuzumab and trastuzumab. So basically, I'll be talking on uh, FESGO, which is a combination, subcutaneous combination of pertuzumab and trastuzumab. So this topic and slides are being given by Roche. So the topic is transforming the journey of your HER2 positive breast cancer patients. So these are the disclaimers submitted here. So we all know Perzata and Herceptin combination. It has changed the treatment landscape. It is the standard of care for patients with HER2 positive breast cancer as of today in all three settings, that is neoadjuvant, adjuvant, and metastatic. There is a definitive role and it has shown advantage. So the pivotal studies which were there was in neoadjuvant was Neosphere, which had shown the improvement of pathological CR rates from 31% to 49% as compared with trastuzumab plus chemotherapy alone. So additional studies were Trefina, Bernice, and Peony. In the adjuvant early breast cancer at high risk of recurrence, we know Affinity, which showed it reduced the risk of recurrence or death by 23%. And in the node positive early breast cancer, so the risk of recurrence was reduced even further to the tune of 28%. Again, the evidence, supporting evidence by Bernice. And metastatic, we know we had Cleopatra, which showed the advantage of adding pertuzumab to trastuzumab, increased PFS from 12.4 to 18.5 months. Clearly a gain of 6 months approximately. And the median OS also increased significantly with addition of pertuzumab and trastuzumab, which was 56.5 months versus 40.8 months. So there is no denial that Perzeta definitely added to Herceptin adds value in the management of patients with HER2 positive breast cancer patients. So this is a simple diagram which shows if we have to use neoadjuvant, newly diagnosed HER2 positive. So this we all know the paradigm. If we use neoadjuvant earlier, if there is residual, we switch over to TDM1. Otherwise, there is pathological rate. We continue with pertuzumab, trastuzumab combination. So, but there are challenges. Challenges like giving the IV infusion of pertuzumab and trastuzumab. It is well established, but it definitely is challenging both to patients, healthcare systems, and the treating physicians. Why so? Because we know it is an IV administration is required, for which a proper setup is required. And IV means it will be infused over a period of time. Minimum, it will take 4 to 6 hours. Why so? Because we need to give pre-medication to settle the patient, give pre-medication, then the mixing of the drugs will come, then it will be infused over a specified period of time. For 2 agents, it takes about 90 minutes for 60 minutes for pertuzumab and 90 minutes for trastuzumab. Then again, we need to give a gap of about an hour between the two. So it takes time. So in a resource utilization may be challenging because it will definitely require occupation of the bed. It will require more staff looking after the patient. Then definitely, as it is a IV thing, we need to have a IV access, which is challenging at times. And again, either we need to have a placement of indwelling catheter, which again requires time, effort, money, and procedure. So to come over this, a novel combination has come, which is FESGO. It is the first formulation in oncology to combine two maps, which is pertuzumab and trastuzumab, in one vial for subcutaneous injection. So it contains the same antibodies as approved for IV pertuzumab and trastuzumab, but it has a different route of administration. So it is formulated with recombinant human hyaluronidase to allow subcutaneous administration of higher drug volumes. We know it is very difficult to give more than 1 ml of drug subcutaneously. So giving 15 ml definitely is going to be challenging. So that's where the role of this recombinant human hyaluronidase comes into play. And it is a ready-to-use fixed dose formulation administered by subcutaneous injection in the thigh, and it takes approximately 5 to 8 minutes. So we know the mechanism of action of pertuzumab, trastuzumab, and the fixed dose combination for subcutaneous use. We know how the pertuzumab and trastuzumab acts, but the thing is hyaluronidase, what it does. So basically, it is an endoglycosidase, which is used to increase the dispersion and absorption of co-administered drugs when administered subcutaneously. We know our subcutaneous matrix is composed of hyaluron and collagen. These are the two main matrix which which synthesize the matrix. So hyaluronidase increases the permeability of the subcutaneous tissue by depolymerizing hyaluron, and this is reversible, and the permeability of the subcutaneous tissue is usually restored within 24 to 48 hours. So what is the impact of this recombinant human hyaluron 20 on subcutaneous injection of large fluid volumes? So we know this, we already talked that subcutaneous layer contains a matrix of hyaluron fibers and collagen fibers. So usually the volume that we can inject subcutaneous is not much. If we inject more, it is going to be painful and it requires large surface area is required. So usually giving more than 1 ml is challenging. So as I said earlier, it degrades the hyaluron locally at the injection sites, and the degradation of hyaluron results in temporary increase in the local subcutaneous dispersion rate, which is reversible. So the skin architecture is reformed within 1 to 2 days due to rapid clearance of hyaluronidase. So, but with the advent of this, we can administer large volumes, even more than 1 ml. So this is one picture which is showing if we have to give bolus infusion with and without recombinant hyaluronidase. So giving 10 ml before infusion will look like this. We all know if we give 10 ml subcutaneous, what it will look like. It will be a big blob. It will be painful and it will be difficult to it will be very inconvenient for the patient also. But with administration along with subcutaneous, recombinant hyaluronidase, so immediately even post perfusion, we can see the swelling is very minimal and it is very noticeable and it is quite acceptable to the patient also. So again, so okay, the drug is there. So the question arises: does this trastuzumab pertuzumab fixed dose combination subcutaneous, does it has the same pharmacokinetics? Does it has the same efficacy and safety as compared to the IV formulation of these drugs? So to address this, there was a clinical development program. So first, the dose was confirmed based on this BO 30185 study, and it was completed in May 2018. Then the doses after this had come to 1200 milligram of pertuzumab and 600 milligram of trastuzumab, and maintenance and 600 milligram of each. So we know here there is no calculation according to the body weight. We are giving fixed dose combination. So the same thing was checked again. The PK, the pharmacokinetics, efficacy, safety, and preference was checked in various studies. The important of which were Federicia, phase 3 study in early breast cancer. There's another study which is ongoing. The primary analysis was presented in SABC 2019. The other study was France subcutaneous study, and it is a phase 2 ongoing study, and primary analysis was again present in ASMO 2020. So this was the study. This is how the dose was decided. There were different cohorts. We will not go into detail of this. So cohort 5 was selected based on the studies and the analysis. So in summary of this study, so the dose of 1200 milligram of pertuzumab as loading dose and maintenance of 600 milligram was chosen, and the dose limiting finding processes was the same, which was used for finding the dose of Herceptin and MabThera subcutaneous. So it was done in healthy male volunteers and patients with early breast cancer, and it was determined to be equivalent. And as per safety, there were no new safety signals observed for pertuzumab subcutaneous alone, or when co-mixed or co-formulated with Herceptin subcutaneous. Because this issue again sometimes comes in mind. We are mixing two monoclonals. Is it going to change the efficacy, or is it going to cause any problems? So the Federicia was the study. Here they have done the PK efficacy and safety analysis. So I will not go into detail. The primary endpoint of the study was non-inferiority of at cycle 7, pre-dose cycle 8 stuff levels were taken, and the secondary endpoints were the same, and the safety IDFS. So if we look at the pharmacokinetic parameters, which are important to understand in the bioequivalence between this IV and subcutaneous formulation. So we can see, obviously, with administration, the Cmax will be highest with the IV administration at the time of injection. But if we look slowly with the subcutaneous injections, as the time passes, the Cmax increases. But if we look at the area under the curve, which is likely to be more or similar with the two formulations. So again, if we look at this, the primary endpoint was to know what was the C trough levels. So C trough levels were better. The lower limit of the 90% confidence interval for plasma serum C trough levels were similar. It even exceeded the non-inferiority margin of 0.8, and which was equivalent or better. So if we look at the response rates, so in this study, Federicia, the fixed dose combination, subcutaneous combination had almost identical total pathological CR rates as compared to the IV thing. So if we look here in the intent to treat population, it was comparable, 59.5% in the IV formulation versus 59.7% in the fixed dose combination. But they have done this analysis according to the BMI also. So in underweight, it was different. Otherwise, in the normal and overweight patients, it was better or equivalent. In obese, it was numerically below, but was equivalent. So the conclusion of this was that pathological CR rates in intent to treat population are keeping it with the data from previous studies of IV, trastuzumab and Herceptin study, plus chemotherapy in the neoadjuvant setting. So coming to the safety profile. So if we look at the phase 3 and there's grade 3 and more than grade 3 toxicity, it was almost equivalent, numerically less, but statistically not significant. So it was well tolerated, no new safety signals, and the rates of treatment discontinuation due to AEs were similar in both the arms. So most common AEs, again, they were similar, more alopecia, less of nausea, little more diarrhea, less anemia, and less asthenia. But statistically, they were all equal. So if we look at the side effects or adverse events of interest, which matters, so which are diarrhea, cardiac dysfunction, analysis, and interstitial lung disease. Again, they were similar and not statistically significant. So in the nutshell, there was no meaningful difference in cardiac safety between the treatment arms, whether it was IV or subcutaneous formulation. So if we look at the fixed dose trastuzumab pertuzumab subcutaneous combination, it showed non-inferior PK as compared to IV formulation. with comparable safety and efficacy. So that the pathological CR rates were equivalent, nearly identical in both the combinations, and the safety was comparable to that of the IV formulations. So again, so this is okay. So we have a formulation and there is data which says it is equal. There are no safety concerns. But what is the patient preference? Was any study done to know the patient's preference of subcutaneous versus the IV combination? The France SCA study it is a phase 2 study assessing patient preference for subcutaneous versus the IV formulation. The patients who were HER2 positive EBC, who had completed neoadjuvant chemotherapy and surgery, they were randomized to a crossover study. So initially in one arm, there was IV formulation followed by subcutaneous formulation. In the second arm, there was subcutaneous followed by the IV arm. After that, 3 cycles of each, they were allowed to choose whatever they wanted. And they were, after completion of the study, so these were the results. So patients were asked, so which is the method of administration you preferred? So mostly they said they were satisfied with the subcutaneous formulation and clearly outnumbering the IV formulation. So there was a clear and strong favorability in towards the subcutaneous formulation. The main reason for subcutaneous preference was less time in the clinic, more comfortable during administration. And about 87% of the patients, they chose to continue with the subcutaneous formulation. So again, the patients were very satisfied with the subcutaneous combination. And it was 88 versus 68% according to this study. And treatment had no impact on patient-doctor interaction time. And even the patients had enough time to talk to their healthcare providers. So the majority of patients felt that switching from IV to subcutaneous would save time and resources, which we all know may be meaningful and better. So no new safety concerns, again better. So reasons we know is more patient satisfaction, less burden on the healthcare system, and equally safe. So what are the practical considerations? This I will not give in detail because administration of this thing is safer, requires little training, but is manageable with the same safety profile. So what does it mean for patient and healthcare physicians? Basically, this is the in summary in the nutshell: shorter administration time and observation period, less burden on patient cares and providers, less invasive administration technique. We can do away with IV access. So it may help reduce risk of dosing errors, reducing drug wastage, and increasing the availability of nursing and pharmacy staff for other tasks. So required time required for drug preparation administration can be, it is not there as it is it comes in a fixed dose combination ready to administer, and there were no new safety signals which were observed. So overall summary, it is a first formulation in oncology to combine two MAPs, trastuzumab and pertuzumab in one vial for subcutaneous injection, and offers faster and less invasive method of administration as compared with IV formulation. So the concentrations were equal. The pathological CR rates were almost identical between subcutaneous and IV formulation in the intent to treat population, and it were not impacted by the BMI. And majority of patients preferred subcutaneous formulation for the understandable reasons. And the majority of healthcare physicians thought that the switching from IV to subcutaneous formulation would save time, resources also. So now this is FDA and EMA approved for the same indications as that for HER2 positive early breast cancer or metastatic breast cancer, with or without concomitant IV chemotherapy. So with this, I'll thank you. Thank you very much, organizers, for giving me this opportunity. If there is any question, I'm happy to answer.
Sir, with your permission, I just want one or two concern.
Yes.
Sir, we usually calculate Herceptin dose at the by body weight, like 8 milligram loading dose and then 6 milligram maintenance dose. So here these are
fixed dose combinations.
here this is fixed dose combination. So whether any like body weight cutoff from on the above, we can give this drug. Otherwise, below that,
See,
we
they
can't.
have mentioned this in the study, but we need to check the product, this thing, the monograph. What they have recommended, whether we can, there is a weight cutoff. So we need to go there, whether there's a weight cutoff like 30 kg, 40 kg. But what they have shown here is according to BMI. So as per BMI, they have shown even if the patient was obese or underweight, there was no difference in the outcomes or the toxicity, which is of major concern.
Okay, sir.
But again, need to check the product monograph. This is a very good and intelligent question. I did not give it that much of this thing, because we get to see all kind of patients in our practice. Some are very like thin, cachectic, and malnourished. Yeah, it's a very good question. Yeah.
So, sir, thank you for such a wonderful presentation. And over to Dr. Kumardeep, sir. Sir, are you there?
Hello, Varun. Hello, Dr. Varun.
Yes, sir.
Thank you, sir. Thank you. It is, you are a good teacher, I must admit from you. How to manage EGFR mutant NSCLC. Over to you, Dr. Barun.
Sir, that session I have already taken before Dr. Sumit. So, so we will close today's session now. We will meet again for tomorrow, and with few more topics to discuss and to dwell upon whether. So, with this, good night, everyone, and thank you all.
Thank you, Dr. Varun. Thank you, Dr. Kumar. Thank you very much. Thank you, organizers.
Thank you, sir. Good night.
Bye.
Support team, we can close the meeting.